Should we wait a minute or just go?
Wait a couple.
Cool.
So they're pretty handy. The PowerPoint is not showing the power.
What's it showing?
Oh, really? Yeah, it's just showing like a like this, as if like it's still in the presentation. Yes.
One more try.
Go. Oh wait. Go hit. So what they're viewing is the PowerPoint page.
Mm-hmm.
So
I think if you just do share, entire screen.
yeah, and then we can just fill it with our screen.
Exactly.
Perfect.
There you go. Cool.
All right, we'll give it a couple more minutes. Did you have to do any cases today?
Yeah, in clinic.
Oh.
I got out
What
of
are the
the.
clinics like there? Massive?
Yeah.
Okay, Rachel started.
I just long. Just talking about all of the options. So there's. We can do this. Tomorrow, I'm actually going back tomorrow just to help out. We need help. Tomorrow we're doing a orbital advancement. Wow, that's pretty cool.
What's the indication?
They have congenital, like a Robin.
Oh,
so
Robin.
I guess I'll ask you.
You go here, hairline, peel all the way down, and then make your like osteotomies. And then, I'm sorry? Yeah, make the bones of the sutures. And then you can actually put a device in that you can turn, and it'll slowly expand it. If they're still growing, you can do that.
How old is that?
So this patient is in young teens, like 12.
So it has to be done before you puberty, before this.
Yeah, before closures. Better if it's a baby.
Have you seen it?
Yeah, some of them look really good. This is like the one thing that actually looks really good.
I can use light altering for sure.
Mm-hmm. I did a mandible with a fibula the other day, and that one looks really good too because you're able to keep all of her skin and just like flapped up and rebuilt the mandible. That one looks good because we're talking about if it looks good or not.
A lot of times it takes a while for them to look good too.
Yeah. We have a couple. What are you up to? What do you want?
I am. That's the fun one.
So all we started.
I mean,
I'm post class right now. I'll be at 7 for the last 6 weeks.
Nice.
And then we go back.
When do you go back to that?
I come back in 3 weeks. So I have cardio next, and neck after that. And then it's not. We'll see how that goes.
Tanya, what are you doing right
are
now?
you like actually
I am.
county when you do the customers, or is it like UICF?
I'm in ICU.
You do
Oh,
yeah, you are.
Silly Pond?
No, after
It's very
It's
silent.
pretty cool.
I've heard it. Hey, Silly Pond's probably my
A lot of
favorite.
our
I missed
OR
out.
nurses are actually over there also. They ran into quite a few people. April, next April.
She has a very, how do I say it nicely?
I saw about 3-4 weeks ago.
She's
and I'm
cool.
like,
Huh?
She's
I saw her today. Like,
She just goes on.
oh,
I know. I remember thinking, because she's really scurrying around, and I'm like, how?
yeah, I saw her walking in. Oh my gosh, she's horrible.
Because then I'm like,
When I first met her,
Because that UIC is.
yeah, she is too. Yeah.
Oh, I know that. So she's done that. Right?
Yeah, so she is doing a breast scholarship.
Oh, that's cool.
Yeah, so it's all this new way.
Yeah, she's probably happy. Looks different. I didn't see her though.
I have to have breakfast with my kids this morning.
Oh,
I know, I still feel like we should have combined residency or, just because we go through. Not to be.
I didn't get that. No.
I didn't, and then maybe put a little on perspective.
I was just gonna say that.
For example, since you're plastic surgeon going to do breast reconstruction, it makes sense.
It's actually like I was when I did my breast rotation. I don't hate this. I like this. I like the patients. Whatever. But the one thing I hated is that we cut it off. We just hand it off to somebody else.
I know.
Let's do it. Can you guys hear us on the internet? You can hear me? Okay, cool. Okay, so my name's Herron. I'm a 4th-year resident here at Sinai. This is a presentation on abdominal pain. If people out there talk, can we hear them?
They have to unmute themselves.
Yes. Okay, so this is, I have a lot of questions in this PowerPoint. You will not be yelled at to read more if you get them wrong. It's a fun learning experience. We've all been med students, so I remember. But the more interactive, the more you guys just like say what you're thinking, the more less I have to talk. So that would be great. Okay, so abdominal pain. So I have 3 different scenarios. And then throughout the scenarios, we'll just talk about some different things. So first scenario, the ED calls you, and it's a 22-year-old previously healthy female with a 20-hour history of acute onset abdominal pain and some mild tachycardia. So the first thing when you get a call like this is you kind of be thinking, running through the gears in your brain about what possibly could this be. So just 22-year-old female, acute onset abdominal pain. It hasn't been going on for very long, less than a day, and she has mild tachycardia. So just what are some things going on in your guys' heads? Pregnancy, appendicitis.
Ovarian disruption.
Yeah, exactly. Very torsion, perfect. Anything else? Sure, cholecystitis, right? I didn't tell you where the abdominal pain is. Exactly. Sure, that is not on my differential, but yes, that is 100% accurate.
Differential of exclusion.
Yes. Yeah,
Like diagnosis of exclusion.
exactly. Yes, however, 22-year-old previously healthy female, less likely. So differential, you guys pretty much got all of them up there. Ectopic pregnancy, acute cholecystitis, appendicitis, a UTI, pelvic inflammatory disease, another UTI, tubo-ovarian abscess, or ovarian torsion. Are kind of the top things that would come to my mind if I got a call about a female in reproductive age who has acute onset abdominal pain. So where do you start when you get a call like this from the ED? So when you're getting a consult, whether it be from another service or from the emergency room, whoever you're getting the consult from, you have to ask them some questions. So is the patient stable? Or are they unstable? What has already been done for the patient? Have they had 2-liter bolus and they're still hypotensive and tachycardic? Have they ordered blood? Have they started antibiotics? All those things. What has already been done? And then what's still pending? Like, hey doc, I ordered a CT scan of the abdomen. It's still pending. So you know what to follow up on. And that's a pretty good handoff. So the same thing, if you were calling somebody else with a consult, you would want to include that information. What you have done, and then what is still pending. And then a brief chart check. Some people say go see the patient first. If the patient is unstable or really sick, go see the patient first. However, if you have time to get just like a brief amount of information so you know a little bit about the patient before you go see them, that will go a long way. So just looking in the chart, quick vitals, quick labs, imaging that's already done, like brief history. We're going to get Epic soon, so you'll be able to see all this stuff a lot easier. And then a last visit. So is this somebody who's coming to the ED every week with abdominal pain? Or have they never been to the doctor? That can tell you a lot too. And then go see the patient. So for gathering history, there are some like pre-printed out templates you can get that you can just like fill in while you're asking patients questions. But let's say you don't have one of those, you're not on the computer, and you just have to ask the patient all of the questions that you need. So these are something that you'll ask all of the patients that you see, and then you'll document it. And this is actually the correct order to do it in. So there is a little mnemonic. My sister always misses social family reunions. Do with that what you would like. But so past medical history, surgical history, allergies, medications, social history, family history, and then review of system. A big one for medications, always to remember, is any anticoagulation, blood thinner, that kind of. I have seen somebody almost bleed out from a breast punch biopsy when they were therapeutically anticoagulated. So just always look. And then when you're asking the patient about their specific problem, did you guys learn old parts in school? Yeah. So this is what you would ask them about their specific pain that they're having or their new symptoms. So when it starts, where is it? How long has it been going on? What are the characteristics? What makes it better? What makes it worse? Does it radiate? Is there any timing associated? And then any other associated symptoms. So our patient, 22-year-old previously healthy female, what kind of things would you guys ask her specifically? Not counting like the past medical, surgical, really allergy history, but just like about her pain. What kind of things would you ask her?
Location.
I'm sorry?
Location.
Location?
Does it radiate anywhere?
Does it radiate?
Trauma happen?
Yeah. Trauma.
Rate the pain.
Yeah, sure. They just have to unmute them.
Yeah, tell them to feel free to pay.
Yeah.
Oh, yeah, I do. Okay, cool, thank you. I just want to make sure that they're.
Is there a way we can view the pupil too?
All tap.
What did you just say?
All tap. If you just.
Yeah. Oh wait,
you
let me
can
see.
see the screen.
Whatever. Okay. Just feel free to chime in. Anything else?
Neosha asked, have you had similar pain before?
Mm-hmm.
Rate the pain and like describe the pain.
Yep.
Give me the sentence, when was it?
Mm-hmm.
Maybe make it better or worse.
Yeah. What else about like this specific patient? Not necessarily about her pain, but some things you just might want to know about her.
Sexually active, her menstrual cycle.
Yep, those are two very important questions. You guys hit most of them. So, fevers, chills, nausea, vomiting, diarrhea, constipation, any loss of appetite. If the patient is hungry, that tells you a lot. Because it means a lot of times that they're okay. If they're not hungry, I haven't eaten in 3 days, that also tells you a lot. They're probably sick. Last menstrual period, is she on any birth control? Pregnancy history is also important. Any abnormal discharge or bleeding, history of STIs, because a history of STI can increase your risk of ectopic pregnancy. If she has an OB-GYN doctor, and has she been to the OB-GYN doctor? And when was her last exam? And then any like burning with urination. So a little bit on physical exams. I'm sure you know about vitals. So normal heart rate is 60 to 100. I don't know how many of you like did sports growing up, but I did, and I'm often above this 100, like when I'm working out or exercising. So a lot of times early in med school, when I would see a patient who had a heart rate of 110, 115, I'm like, hey, that's pretty normal. But that's pretty normal for you and me. That's not normal for our 80-year-old sick lady. So just remember, 100 is, if it's above 100, they're technically they are tachycardic. And tachycardia is something very important to note. It is the first sign that your patient is bleeding, is that they'll become tachycardic. And if somebody's leaking, like they have an anastomosis that is leaking, or they have a perforated viscus, the first vital sign that is abnormal is tachycardia. That is a very favorite print question. And then another caveat is if your patient is sick and they are not tachycardic, you want to look to see if they're on a beta blocker, because a beta blocker can artificially lower your heart rate. Blood pressure, can't tell you how many times I've got a call from the nurse at 2 a.m. telling me my patient is hypotensive when their systolic blood pressure is 105. That's not hypotensive. I've heard some people say hypotension is under a systolic of 100, but this is saying 90. And then on the other hand, hypertension is a systolic over 130. And I think a lot of times in our patient population, we get used to seeing a blood pressure of 150, 160, but that is not normal. Respiratory rate, normal is 10 to 20. O2 saturation, normal is 95 to 100. And then a temperature, normal is 97.8 to 100.4. So a fever is greater than 100.4. If somebody is 100.2, they are not febrile. I've been educated on presenting to attendings a minor fever. So if I ever have a patient who is, their temperature is 100.2, I'll just say patient's temperature is 100.2. Now my attending knows they don't have a real fever, but they know that it's 100.2. Right?
Yeah, that's concerning.
Yeah, I'm concerned, but I don't want to be educated
Yeah,
because I know it's not a real fever. So I'm not going to tell you it's a fever, but I want you to know it's 100.2. So abdominal pain, there are some fun charts that help you with where the abdominal pain is and what it could possibly be. Some of it's pretty self-explanatory, like right upper quadrant, cholecystitis. Something to remember is upper abdominal pain can also be pneumonia, and it can also be an atypical MI, heart attack, which is up there. This is supposed to be a 4-quadrant chart, then they gave me 2 extra quadrants on the right-hand side. Anyway, so abdominal pain can also be an atypical MI, more common in women and patients with diabetes. I'm sure you guys have seen this chart before. And then there is a 9-quadrant chart also. Your esophagus is also, the lower esophagus is also in your abdomen. So important to remember that esophagitis can also cause abdominal pain. Once again, this also says cardiac causes, lung problems. Lymphomas are a other not common cause of abdominal pain that you see around the umbilical area. And then, as you were saying, a sickle cell crisis.
Oh, yeah.
So, some favorite named abdominal exam findings. Who can tell me what Murphy's sign is?
Cholecystitis.
But what is it?
That's it. So I believe that you press down on the right quadrant where the gallbladder is supposed to be. That's supposed to inspire, and it looks like you release. If they catch their breath, that's causing them to
If they what their breath?
If they catch their breath,
What does that mean?
like they wince really hard when they are.
You're almost
there.
Oh, you're so close. Anyone else?
It's a halt of inspiration.
Exactly.
Halt of-
So, yeah, cessation of inspiration upon deep palpation of the gallbladder. So you'll wedge your hand up right upper quadrant, and you'll ask your patient to take a deep breath in. Then if they I can't, they stop breathing in, that is a positive Murphy's. I can't say this word. Courvoisier sign. Anyone know what this is?
Isn't this one is like right upper quadrant fullness associated with like cholangiocarcinoma?
Yes, yes, but there's more to it than that.
Does it radiate to the shoulder?
That's a different one. We'll get there. It's on this list. Okay, so you're really close. I don't know. I can't see the people talking. So whoever gave me that answer is very close. So it's a palpable non-tender gallbladder in the presence of clinical jaundice. A lot of times we're taught this is associated with cancer. but it also cannot be in cancer. But that is the standard teaching, and on your exams, if you have a patient with this, it is cancer until ruled out, otherwise proven.
May I ask you a question really quick?
Yeah.
Have you seen this clinically?
Yes, I
Amazing.
have. And we ended up, patient had an ampullary mass, and they were transferred out to a tertiary care center. So if something is like the stretch of an organ, if it is acutely stretched, so acutely blocked like a stone, that hurts. But if it's chronically stretching, it doesn't hurt as much. So masses, they don't like start big, they start small and get bigger. So you have time, which is why it's typically non-tender. But yeah, I've seen this. Not very common, maybe like once or twice. How many times have you used?
Yeah, maybe like once every few years.
Yeah.
But sometimes in elderly people, they have such a patulous abdominal
Mhm.
wall, floppy abdominal wall, that like you can actually palpate their gallbladder, and oftentimes they have atypical cholecystitis.
Yeah.
Or really bad cholecystitis, or by the time they present, the omentum's gone up there and kind of loculated it, so you can feel the gallbladder, but it's not necessarily, cancer.
Yeah.
Thank you.
Yeah. Oh, yes, totally agree.
2/3 thesis, 1/3 from these.
Yeah, so pain on palpation 2/3 of the way between the ASIS and the pubic symphysis. Robsing sign, but
It's when
what is it?
you push down on the lower quadrant, you don't have to, right?
Exactly. So it's a pain referred to McBurney's point when you, on deep palpation to the left lower quadrant. Obturator sign.
It's, you internally, flex the hip. There's internal rotation of the hip while it's like,
You have it, and
you flex, right?
Yeah.
And then you'll find,
Yep, this is, I think that this is incorrect. It is, I believe, internal rotation. Pain upon flexion and internal rotation of the right thigh. And what is this a sign of? Exactly.
Because when you do that, it rotates the appendix onto the obturator, and so that's why that happens.
This is the same obturator hernias test for this. Psoas sign.
that's pain on resisted.
So it's pain upon elevation. So like if they're laying down, it's with the psoas. They're extending and extending the leg, and they have pain in the right lower quadrant. And what is this a sign of? Yep. And if the patient has a positive psoas sign, typically what we're taught is the appendix is most likely going to be retrocecal. And so it's behind the cecum and it's inflaming the psoas muscle, which sits right there. Sometimes the appendix actually is there and sometimes it's not. But that is what we are taught. Kerr sign.
this is it. Right nerve, it's when is it like this, the spleen? Yeah, it's, when it enlarges and presses on the phrenic nerve, and you get like some, shoulder.
Exactly. So Kerr sign is referred pain to the left shoulder due to irritation of the diaphragm, very often seen in hemoperitoneum due to a ruptured spleen. Exactly. And then I'm sure you guys have all rounded with us and you have seen us see a patient after surgery, after they've had a laparoscopic surgery in particular. Like, doc, my abdomen's doing great, but my shoulder's just killing me.
Yeah.
It's the same thing. It's just you insulate the abdomen, the diaphragm doesn't like it, and so you can't feel your diaphragm, and so it's referred to your shoulder. A Gray Turner sign.
I think it's the front half, the columns in gray.
Mhm.
Yeah.
The next one's colons.
I'm gonna say grays in the anterior part, like a big ass area.
So the Gray Turners is more on the flank, but then it can like come around more flank. And what is this associated with? Hemorrhagic. Hemorrhagic. It's bleeding, so you have a bruise.
Why do you think it's in that distribution?
That's a great question. If my,
Because some of it's retroperitoneal, but.
Thank you, good job, yeah.
That's it. It's retroperitoneal, so it tracks in that plane, and you can see it. And then colon sign is a periumbilical darkening of skin from blood. You also get this with hemorrhagic pancreatitis, but what I was reading claims that this is the most common in ruptured ectopic pregnancy. I've never seen either of those. So here's our patient. Back to our 22-year-old patient. So vitals, heart rate's 110. Temperature's 100.1. She is not hypotensive, and she's sounding great. She's in no distress, like we talked about earlier. She's in the ED, so you can see her heart rate on a monitor. So I know she's in sinus tachycardia. Nothing wrong with her chest, and then her abdomen is soft. It's moderately tender to light and deep palpation in the lower abdomen, specifically the right lower quadrant, with voluntary guarding. She's mildly distended, no palpable masses or hernias, and no prior surgical scars. So kind of what are your two things that you're thinking about or worried about? There are more, but appendicitis and ectopic. Those are the first two things, because ectopic pregnancy, if it's ruptured and she's bleeding, she could die. And then torsion is definitely on the list, but you're not going to die. So I have a few more minutes for that one. So what kind of labs? Sorry, got some more history on her. So she also has some mild nausea. She had a normal bowel movement 2 days ago. Takes birth control, is sexually active with one partner. Maybe a few days later on her period, doesn't really know. She doesn't keep the best track. So what kind of labs do you want to get? CBC? What else? CG.
I mean, I would get that.
CBC, pregnancy test, BMP. Sure, the ED normally does it anyway. So yeah, I said a CBC, a BMP, a lactate. Not super important in this patient, but something that we might get. Definitely a urine pregnancy test, and then a UA still, urine analysis still, for sure.
Could you clarify lactate? Is it just like make sure it's not like ruptured appendicitis or anything like that?
Like how sick is this patient? I probably wouldn't order a lactate on this patient. We have other patients in the scenarios that you need to order a lactate on. A lot of times these patients will come to you with a lactate because the ED will order it. Do you guys know what a normal lactate is? Or what's an abnormal lactate? Greater than 2. It's like sepsis lactate.
I'm about to say you order lactate if they're like service criteria is positive. They're probably like service criteria.
You would definitely order a lactate then, for sure. I have a patient who's a little bit hypotensive.
Tachycardic.
Sorry, she's not a little bit hypotensive. She's tachycardic. It's not wrong. If we're going off saving money, you could definitely like hold off on it. The others are 100% important. So the CBC, BMP, pregnancy test, and urine analysis are definite for this patient.
Any thoughts on like a CMP? Instead of a
Ooh,
BMP?
that's my question. So what's the difference between a BMP and a CMP?
It's something about like you get the liver enzymes.
So they're called the liver enzyme.
A BMP include, or yeah, CMP includes your liver
Exactly.
test, liver
Yep.
enzyme.
So I think in the ED, a CMP is never the wrong answer. Either. Never the wrong answer. There are definitely people that you need to make sure you get a BMP on. People you need to make sure you get a CMP on for sure. With this patient, I don't know, right, lower abdominal pain. I'm not super worried about her having gallbladder or liver issue, so I might hold off on it.
Yeah, like
But-
for instance, if they had just ordered that, you would say, oh, let's add on LFTs.
Yeah, I wouldn't add it on, but it wouldn't be wrong. There's a lot of things in medicine that aren't, that like you can do that are it's in like the scope of okayness. So these are labs. What's abnormal? I had to write this down and take a picture of it because I didn't know how else to get labs on here. So, do you guys know how to read these?
Not the one on the left.
The one on the left?
Is that hemoglobin 9?
Yeah. So, you guys, can you guys see my mouse?
Yes.
I don't know if they can
Yes,
see it.
yes, yeah, we can see it.
So, this is white count, hemoglobin, hematocrit, platelets.
So definitely leukocytosis with anemia
Um,
or electrolytes would be.
they're rock solid. They're rock solid. Because I looked at the normal lab values.
But one thing to mention is just not really super relevant for this case, way up what we think. But like CO2, if you don't have a lactate, it will kind of give you an idea of acidosis. So like if somebody had like an 18 or 19, like that's a problem. It means they're probably pretty sick.
And metabolic
Yeah,
acidosis.
another thing you can think of just like in the background of it, like if she's diabetic and all in her history and like abdominal
Something
pain for
after
decay or something like that.
Yeah,
too.
exactly. Exactly. So yeah, leukocytosis and anemia.
What is 17?
BUN.
Oh,
So I got a 22-year-old female who's a little bit anemic. Is that normal? Abnormal? Could be normal. Period. Who is anemia abnormal in? Most patients, but who's it really abnormal in? Yeah, so men and postmenopausal women. A 22-year-old female having periods, hemoglobin's 9. Definitely seen that before in healthy people walking around. So a little bit anemic and a white count. It's not really helping us with our differential. So on your tests, love to ask you these questions. So what is the best first imaging test? So you're worried about an ectopic pregnancy. I know her pregnancy test is negative, but we're worried about an ectopic pregnancy. What is the best first imaging test?
Ultrasound.
Specifically?
Ultrasound.
Specifically?
Trans-
Transvaginal ultrasound, exactly. So transvaginal ultrasound, sometimes you might see something in the fallopian tube. However, the most specific thing would be a positive pregnancy test, but an empty uterus. What about appendicitis? What's your best first imaging test?
Well, it depends on the patient, but most patients.
Yeah, right lower quadrant ultrasound.
How often do you think that's happening?
So, the ED got a CT scan.
Okay. So like, how do you answer that on your self-exam or your website?
Yeah,
Is the question, you know,
Yeah.
when you see it in practice, it's like, well, CT, how could that be wrong?
but your test.
Yes.
the-
Yeah.
that's ultrasound.
Yeah.
However, the ED got a CT scan. So, let's see if this works. It's thinking. This is magic. All right. So, a patient CT scan. Let's start up at the top. And then I'm not going to mess any buttons to make this zoom, so we're just going to go. Okay, so here's our lungs.
Can I interrupt?
Yes.
For a second? The very, very, very first thing that you do when you're looking at imaging.
or yourself, like the type of image.
Okay, well, what else?
Patients.
Thank you. So you always want to make sure you look at the patient's name. I know it seems like kind of funny and flippant, but like, trust me.
Yeah, off of that, I would also look at the date that it was actually done.
Yeah.
Are you looking at the one that was just done or one from a few days ago?
Yeah.
Yeah.
Looking at the old one like, oh wait, this is 2 years ago.
Oh, shoot. And then, so what side is the side of the patient?
Right.
right? And then this has the left, top, bottom, and we're looking up. So here are lungs and our heart. And so the things that I look at is I really like this view right here a lot. And I look right about right here because you can see a lot of times free air. The patient has free air. Let's look at some other CT scans later. And then what's this? Spleen, and this stomach, and what's this?
Liver.
Liver,
And here, these two little things.
kidney,
What about this guy? Cool.
gallbladder.
Okay. So I'm gonna scroll down. Anybody see anything a little bit weird right here? Yeah. Where is that?
Is that the end of the bowel?
Is that right?
What's in the right lower quadrant?
The appendix?
Yeah. So what might this be?
The fecal exam?
Yeah. Fecalith, appendiculith is another word you'd hear it called.
Yeah.
And this thing right here is an inflamed appendix. You can see it right here too. Keeps going. Very tubular, hyperemic structure. Looks different than the other surrounding bowel. It's fluid filled, has a different density. So yeah, this is a appendicitis with an appendiculith.
That's a really good view of how the wall is enhancing. So when they say it's hyper enhancing, that's what they mean. Like, go to that transverse cut. Like, see how it, right?
This is how, yeah, it's thick and green. You also might hear like some fat stranding. Can't really see anything to point that out to you on this. This one.
Above. Like before you get to it. Like, yeah, kind
Is
of
that wrong? Like right here?
next one. No, other way. Like there. You see that little fuzziness?
Awesome. Okay, back. Yes. Okay. So you also get a CT read that tells you your patient has a small volume pelvic fluid. Are you worried? Who is this normal in? Ovulating women. So ovulating females, small volume pelvic fluid is 100% normal. I've had many interns, med students over the year come up and tell me this patient has free fluid in their pelvis. I'm really worried. Then I realize it's a female. It's normal. So abnormal in men of any age and abnormal in postmenopausal females. So female, so back to our patient. The CT scan shows a dilated appendix with associated fat stranding. What is the diagnosis? And what do you want to do for her? No. No. Love it.
Wow.
Yeah. Yeah. So holistically, you're an intern. You got to put in some orders for this patient. You're gonna make her NPO. You're gonna give her some fluids. What else? Some pain meds. Yeah. So eventually, what our eventual plan is going to go to the operating room.
What about this whole thing with like non-operative management of appendicitis?
Yeah.
It looks like
Is
a
that
very
on
early
your tests?
appendicitis. Probably not quite yet,
Okay.
but I'm just curious to
Yeah.
hear what people say. Do you think she's a candidate for?
I think she is. She's
Medical.
stable.
Think a little bit more about the imaging. So she is stable, and it seems early, but there might.
She has
Well,
no
it's fine, it's
obstruction.
okay.
Like people.
Yeah.
Inside.
So that's actually like a contraindication, because the problem is like what happens is it pushes on the wall of the appendix and the blood flow to the area goes low, and so then it gets ischemic and necrosis and higher risk of perforation. So if she didn't have that, theoretically she'd probably be a candidate for medical if you felt comfortable with that,
What would you do medically if it was like
Just antibiotics.
just antibiotics? And what would you like a fluoroquinolone or like what would you use?
Yeah.
I mean, they're sending people home from the ER in some places, like University of Wisconsin, they started that whole trial from the ER. And they have like a video for the patients to watch to choose whether they want non-operative or operative management of their early appendicitis. And it's really interesting. It's that cool video to watch. Actually, maybe I'll show it to you guys one day. And it's interesting how many people choose not to have surgery. Because, I don't know. I think historically, since we're so used to like, oh, your appendix comes out, or everyone's heard of that one person or two that like had some tragic outcome from a perfect appy or something. I would think more people would choose to just get it out because they're not feeling good. So other contraindications would be like elderly people, but it tends to be the people who choose it more often because they have a higher conversion rate to like having a recurrent episode and needing something. So you don't want to miss it. Reserve is a little different. But yeah, I don't think that's on your test of appendectomy.
Yeah. Laparoscopically. Yeah, okay, so you're gonna take patients to the operating room, so NPO, IV fluids. I'm gonna give this patient antibiotics now too while they're in the hospital. Zofran, make sure, because she's nauseous. And then with the plan to go to the operating room. How emergent is this? Does she have to go now? Can she go in a couple hours? Can she go tomorrow? Can she go next week? Not counting the non-operative management.
She's stable, so I'm pretty sure we can just monitor her, and if she's fine, maybe get a little further next morning.
Yeah, so it's not emergent. So depending on the schedule, my availability, patient, what time it is, go later that day, the next morning. Okay, so same patient, you get the CT scan, but now it shows that she has a fluid collection in the right lower quadrant, and you can't see her appendix. What is this?
Perforated.
Perforated appendicitis. And what do you do for perforated appendicitis? This is one of the first patients outside. Okay, your test or like Stan, how do you think you manage perforated appendicitis? And the same patient, she's stable.
Antibiotics and then go back.
Yeah. So this is you do not go to the operating room right away. You drain it, if you need to drain it. If there's a big abscess, if the abscess is accessible, typically drainable abscesses are greater than 4 centimeters. So if she had a little 2-centimeter abscess and she's stable, you don't need to drain it. But drain it, antibiotics, and then you're going to come back later for an appendectomy. However, if your patient is getting sicker and sicker and sicker and sicker despite your drain and maybe another drain and antibiotics, then you have to take them. It sucks because they're all inflamed, they're angry, everything's tearing, so it's not the best time to operate, but they're getting sicker, that's what you're stuck with. But the point of this is a not sick, ruptured appendicitis. The first step is not the OR. It's antibiotics and drain, and then come back later.
When would you come back later? Like how
6
long?
weeks.
Oh,
Yeah.
6 weeks, okay.
After 6 weeks, basically.
So it's not-
A lot of people don't come back. Yeah. They're feeling better. So a lot of people don't end up getting neuropathy. I think a high proportion of people don't. But then they get a higher risk of recurrent appendicitis. And then the only other thing with this one is 20 hours. So for your exam, I agree, like drain and antibiotics for fluid collection. But when they come in, and let's say it's not a well-defined fluid collection, and it's been kind of a short interval, like less than 48 hours, I don't think it's, the wrong thing to do to like take them
Yeah.
time if it's kind of, early.
And we definitely thought appendixes were not ruptured and gone in, and it has been ruptured, but like it's whatever, it's just a harder case. So, and it's not the end of the world.
Do you think it depends on the attending, or is it just there's a certain guideline to follow that?
Art of medicine.
Huh?
Art of medicine. Depends on the patient, depends on the OR schedule, depends on your attending, depends on a bunch of things. Unfortunately.
Follow-up question.
Yeah.
Was this a follow-up CT scan after?
No, this is a different patient.
Oh.
Different scenario.
Okay.
Yeah. Okay, so kind of gotta ask questions. Anything else about that patient?
Yeah, so how would you present that to your attending? Or do you want somebody?
Oh, you want me to do it?
Yeah, do you guys,
Okay.
somebody want to try? Take a chance later. So we'll let her give the first example.
Okay. So, hey, Dr. Herron. What I would say, I know what it is. It's acute appendicitis. So I would start with that. Hey, Dr. Herron, I have a patient in the emergency room with acute appendicitis. It's a 22-year-old female, otherwise healthy. Pain started 20 hours ago. Nausea, vomiting. No past medical history, no past surgical history. On exam, she's tenderness to the right lower quadrant. She's not peritonitic. CT scan confirms findings of acute appendicitis. I would like to start her on fluids, make her NPO, antibiotics. When would you like me to schedule her?
Yeah. And what if you had to like sign that patient out and you just gotten a call that, you know, her temp's up to like 103 now, and you're on your way out the door?
Yeah. So so this exact scenario, now the temp's 103. We haven't gone to the operating room yet. So I would tell like talking to my intern or my other co-residents, tell them all about the patient. So everything I just said to Dr. Herron. So all the information about the patient. But then I would say I've done this. So the patient is NPO. I put them on IV fluids. I started them on ceftriaxone and flagyl. I just got a call from the nurse that the temperature is 103. The patient is scheduled for surgery later tonight. I have not done anything about this temperature yet, which is not the right thing to sign out. You should always do something about it before you sign it out. But can you start them on Tylenol? And can you please let Dr. Herron know that the patient's temperature is up? Would also consider probably getting blood cultures.
Yeah. And let's say that the surgery is not scheduled for later that night, maybe it's scheduled for the next morning. So that's why it might be important to let your attending know, because we might decide to do it right away.
But if you definitely have, like, when you're a resident, if you have a patient that has something happen and you're aware of it, it's definitely better to, if you get a call from the nurse, the patient's temperature is 103, it'd be better if you order the Tylenol, you order the blood cultures, you text Dr. Herron, but then you tell them to please just follow up on the results.
And some residents like to keep you in suspense and tell you the whole history and exam and CT, and then you're sitting there like, don't know until the very end. Because you're like,
Yeah.
So that's fine. There's a couple little quick things with this. So
Yeah.
when you're in that age group, 22, like these young adults, sometimes they get atypical things that are related to pediatric population. So like Meckel's diverticulum, volvulus malrotation. Like, I mean, yeah, you could be 20 and just now get diagnosed. So like sometimes it's atypical weird stuff to always kind of keep in the back of your head. Other things, young women, they get splenic artery ruptures, so like, you know, it might not just be a ruptured ectopic, or those hepatomas that are like rare stuff, but just, you know, kind of always keep like an inclusive mind for like differential diagnoses. Also, if you have a patient with like exam findings out of proportion to their vitals, or vitals that are out of proportion or just don't make sense compared to their exam, you know, that would be a reason to continue investigating, or at least serial exam, bump it up to, you know, senior person if things are just not making sense. Then you also have to remember, outside of like beta blockade, elderly patients, I'm always talking about that. They just do not have the normal, I don't know if you call it reserve, but they may not get tachycardic, you know, they may not get hypotensive.
Also, a lot of times have less pain.
Never have pain,
Yeah.
especially for bowel obstructions. That's my thing.
Dead gallbladders, no pain.
And then sometimes you have substance abuse with folks, and so their vitals are crazy, but their exam is not, or maybe they're not having the typical pain because of substance. So that's something important. So definitely, if something does not make sense, you want to keep investigating and at least do serial exams and document those things as well. You know, if you're going to see somebody, write it down.
Yeah. You didn't do it if you didn't already know. Okay, next scenario. Now we have a 41-year-old male, past medical history of peptic ulcer disease and GERD. He presents with a 1-day history of upper abdominal pain and fever. What are you thinking? PD. Cool. What else? Good. Mhm. It's not wrong. But don't get pigeonholed. What else could it be?
Well, you always check for like heart, like MIs, and it could be like some outpatient with
Yeah,
abdominal
sure.
pain.
I agree with that. I actually gave this I was going over this presentation with other med students at UIC, and she also said that. I think the presence of a fever
Yeah.
makes an MI a little less likely, but not wrong to order tropes.
You never know.
Yeah, definitely. I'd say not. I would be safer than not. So not wrong. Pancreatitis. Yeah, could be a perforation. Sure.
It still be a gallbladder issue if they have like the
100% could be a gallbladder issue.
Could be pneumonia, but a
Pneumonia?
lower.
Could be 100%. Also, people with GERD, they can aspirate. Could be a pneumonia. You're saying it,
Liver.
yeah, could. Probably see a few other things. Have some interesting history in order to get a liver abscess. But if I had those things present, the patient could have abdominal pain and fever. Yeah, you guys hit most of them. So gastritis, peptic ulcer disease, pancreatitis, acute cholecystitis, and perforation. So history. What kind of things are you going to ask this patient? All the things, sure. What are you going to ask this patient? Describe the pain. Yeah, where is it?
quality care or
Mm-hmm. Nausea, vomiting.
Diarrhea.
does it hurt more when after you eat or when you have eaten or not eaten?
Yeah, so association of pain with food or timing of pain.
Have you felt this before?
Yep. Have you felt this before?
Any vomiting or diarrhea?
Yeah. I think I saw most of them.
Substance history too, if they drink.
Yep, substance history, exactly. Smoker. I'm thinking one other thing. That's also fair. Not what I'm thinking.
Does he have a history of HIV at all or anything like that? Because it was like esophagitis.
How about history of something else that starts with H?
Oh, yeah, of course.
History of H. pylori. Have they been treated for H. pylori? Have they had the test to cure for H. pylori? Are they currently taking a PPI or is their GERD being treated? I somehow Siri'd my phone. Any new GERD alarm symptoms? So weight loss, coughing up blood, all those things. Any nausea, vomiting? Are they having hematemesis? The timing of pain associated with food, exactly. Has the patient ever had this pain before? And then everything else you guys said, totally agree with. So here's your patient's physical exam. Heart rate's 89. This patient does have a fever. It's 100.4. They're not in any acute distress. There's no scleral icterus, also in sinus tach. Their lungs, we mentioned, could be a pneumonia. Lungs are clear to auscultation, no accessory muscle use. And on our abdominal exam, abdomen is soft, it's non-distended. He has tenderness to palpation in the epigastric area in the right upper quadrant. There is a positive Murphy sign, no guarding, rebound, or rigidity, no masses or hernias. What kind of labs would you order after that?
CBC, CMP.
CMP, yes. Yes. I think same thing. I don't sort of my face. So here are my patient's labs. And a T-Billy. T-Billy doesn't come with a CMP. So it's the same like a liver enzyme, so you'd also add a T-Billy. So CMP and a T-Billy. So what's abnormal in this patient? White cells, yep. T-Billy is elevated. It's above 2.5. Yeah, not scary, just a little bit elevated, right? What about lipase?
That's the borderline, right?
Yeah, so do you guys know the lab value to which you would diagnose pancreatitis? Close? 3 times. So I once presented to our old program director, I think this patient has mild pancreatitis. Nope. You either have pancreatitis or you don't. And it was 3 times the upper limit of normal. So it's every lab thing is different. This was 60. The 60 is the upper limit of normal for this. Have you seen 60 most of the time?
Yeah.
Yeah, it's like 60, 70. They'll give you the normal range when you're looking at it. So it's just whatever above, 3 times above that.
Any thoughts on that 14 hemoglobin? Yeah, but why? Possible reasons. Yeah, good.
Dehydration.
Hemo concentrated. Dehydrated, mostly.
Okay, so Coley, what? I remember when I was a med student, I did not know, like, what the heck is the difference between all these things, right? So, what is biliary colic? Anyone know?
Well, the stone that keeps going in and out of the system duct. And so they get like the colicky on and off.
Yeah, so it can be a stone, doesn't have to be a stone. It's pain when the gallbladder is contracted. What about biliary dyskinesia? It's not moving, right? Gallbladder is not working, it's not pumping the right way. What's cholelithiasis? Where? In the gallbladder. Exactly. Is the gallbladder angry?
No.
No.
Gallbladder. What about acute cholecystitis? Gallbladder is angry. Choledocholithiasis? Common bile duct. Yes. What gallstone pancreatitis? Yeah, so it's a stone. Typically, it's gonna be like right here. You guys can't see me over there. You have to use mouse. Like right here, and it's gonna be blocking the pancreatic duct, and so your patient is gonna have pancreatitis. What about cholangitis? Yeah, but what is it?
When you block the
Sure.
bile duct, you get back up and
So where is it? Sorry, what are we blocking?
the bile duct.
Common bile duct. And how does this patient then look different from a choledocholithiasis? So they're a lot sicker. They're now they're infected. They're obstructed and sick. So that's what you're talking about. I got Charcot's triad and Reynolds pentad. And these are one of the favorite pimp questions for cholangitis. So I've had, sometimes the test will try to sneak you in a patient with cholangitis, but not make it completely obvious. So these are the signs that you look for. So if your patient is jaundiced, you don't get that really with a choledochol or acute cholecystitis ever. They're sick. So what do you do? So what is this wording? The next best step. So you have a patient who comes into the ED with right upper quadrant pain. What is your next best step? What would you order? What imaging would you order for a patient with right upper quadrant? Right upper quadrant ultrasound. Okay. I'm worried my patient's coming in to me, they're complaining of some biliary colic type symptoms. What imaging would I order? Patient's worried about, they have biliary dyskinesia symptoms. Right upper ultrasound, cholelithiasis, right upper quadrant ultrasound. Do I have to do anything for a patient with cholelithiasis? Can I? Yeah. So if it's symptomatic or not. So if my patient is symptomatic, what are kind of like the two options?
You could do cholecystectomy.
Yeah, I can take a gallbladder out. I need to tell my patient, you know, I'm not 100% sure this is going to help your pain, but, you know, we can try it. I can take out your gallbladder. This is when there's like a medication.
Oh,
You know, yeah, like the cholecystectomy or whatever.
Oh, yeah.
Honestly, I have never ordered it. I've never seen an attending order it. I had an absite question that gave me a patient with acute cholelithiasis, absolutely did not want surgery. What could you do for her? And that was the answer.
What medication would you?
That one was like ursodiol. Yeah. So then acute cholecystitis, where I talked about, we're going to get a right upper quadrant ultrasound and then do what? Cholecystectomy. Speak up. So what is this an image of right here? Sorry, what procedure? What are they doing? ERCP. Exactly right. And what is this an image of? An MRCP. And what is the difference between an ERCP and an MRCP? Mhm.
Manually retrieve
So which one of these is diagnostic?
Oh.
Both. Which one of them is a treatment?
ERCP.
ERCP. Exactly. So ERCP is both diagnostic and a treatment, and MRCP is imaging. So you have a patient, slam dunk cholelithiasis. Your test gives you an option between an ERCP and an MRCP. What is your next best step? Slam dunk cholelithiasis. ERCP, because I can find the stone, I can shake out the stone, I can put it in a stent, I can do sphincterotomy, whatever. So I have a patient that's maybe, it's not a slam dunk, their T-billy is a little bit elevated. I get my right upper quadrant ultrasound, but it, you know, maybe the compound is a little bit dilated, don't see any stones, you're not sure, then you can get the MRCP. Gallstone pancreatitis. What would I do with a patient with gallstone pancreatitis? ERCP. Why? Cool. Okay. And then I take out the stone. What do I do with the gallbladder? Well, I get a call from the ED. Hey doc, got a patient with gallstone pancreatitis. You want to take out this gallbladder?
No.
When?
Resolved. Yeah.
So we gotta take out the stone. If there is a stone, sometimes if you see the patient's already getting better, because sometimes they would have had a stone, got pancreatitis, they passed the stone.
What else do they do during that ERCP? Well, what is a potential complication of the ERCP? Like ERCP. Yeah. Why?
Because it's irritating the.
And sometimes part of the procedure is what? Just extraction. So anybody know on there what would be sphincterotomy? So just kind of opening it up a little bit.
Do you guys know what Emperor Vader stands for? What it means in English?
No.
You had a base or something like a chip of base or something?
That is Takisugos. That is the octopus face. So Emperor Vader is the nipple of death. Yeah. Yeah. So Emperor is nipple, Vader is death. So pancreatitis is bad. It hurts really bad. Emperor Vader. Fun facts by Karen. And then you got cholangitis. What's your next best step? What would you do out of these two things? You have a patient with Reynolds pentad or whatever. They're cholangitis. You're gonna take out the gallbladder. You're gonna get some more imaging. You're gonna let them sit there. In ERCP. Yeah. And ERCP is the next best step. Exactly.
Quick question,
Yeah.
itis scan. Which one?
Which one?
Yeah, I think biliary colic would be like part.
Yeah. So biliary dyskinesia, yes. And then if you have other findings, the patient may have acute cholecystitis, but it's not a slam dunk case. You would get a HIDA scan. And if the gallbladder does not fill up, if you don't see the gallbladder, then it means it's inflamed. The cystic duct is inflamed, and the contrast is not getting into the gallbladder. And so that would be how you diagnose it also. They're two different. The HIDA scan for biliary dyskinesia will give you a percentage of the contraction, like how much it squeezes out. And then the HIDA scan for acute cholecystitis is more like if you see it or not. If it lights up or it's absent.
Another quick question. Would you ever forgo an ultrasound, go straight to HIDA, for instance, you're limited by body habitus or anything like that, or person is pregnant, so first ultrasound always?
The person's pregnant, breast test is almost always an ultrasound.
Oh, yeah, duh.
I can't think of a situation where I get a HIDA before an ultrasound.
No, never.
Yeah.
And sometimes they end up with a CT.
Yeah, 100%.
That might be the next, that's probably second to like HIDA is less common.
And then there's actually a lot of times too, I will get a call from the emergency room and it sounds like the patient may have a gallbladder problem and they have gotten a CT scan already, but I actually have to go back and order the ultrasound because the CT scan is not good at gallbladder pathology. Sometimes you can see stones, sometimes you can't see the common bile duct. It's not good. It's not good. So even if they already have the CT scan, it's not like appendicitis where I can just go off the CT scan. I actually have to go backwards and get an ultrasound. All right, so this patient got a right upper quadrant ultrasound. The ED did the correct thing first, and it shows a moderate amount of pericholecystic fluid. That's just a fancy word for fluid around the gallbladder. The gallbladder wall is thick. There is some debris in the gallbladder with some shadowing, and then the common bile duct measures 1.2 centimeters. I'm going to go back to our labs and also remind you that the T-billy is elevated to 2.5. So what is our diagnosis? Choledogo. Acute cholecystitis does not give you an elevated T-billy. T-billy is normal. And then up here, the common bile duct. Does anyone know what a normal common bile duct is?
Isn't it 0.3?
0.6. 0.6. So as you get older, normal also increases. So an 80-year-old may have a 0.8, and that could be normal.
Oh, and with heroin.
What?
With heroin use, the common bile duct.
Maybe. I cannot confirm nor deny. Potentially, I mean, I know a lot of times yeah. So morphine causes constriction of the sphincter, so relaxes it. So I mean, if morphine causes constriction of the sphincter of Oddi, and then heroin is an opioid, could cause constriction of the sphincter of Oddi, which then would cause back pressure buildup.
Right.
So definitely, I've heard that.
No. It was like something that a GI doctor.
Yep. So I got a normal aged male. T-billy is elevated to 2.5, and the common bile duct is dilated. So you called it choledocholithiasis. And what is my next step? What do I do? ERCP. Yes. And then after I do the ERCP, I get the gallstone out. What do I tell my patient about the gallbladder? Yeah.
Same time.
Like the next day,
Yeah.
and take it out.
Okay.
So after they do the ERCP, I would get the next day, another T-billy. Make sure their T-billy's downtrending, meaning that the blockage has been resolved, and it's been resolved, then I'll take out the gallbladder, like the next day. Then they can go home the next day too. Some people can be like, I don't want my gallbladder up, I don't want my gallbladder out. And like, fine, go home. But you would tell them that it's already happened once, it's likely going to happen again. And it might not get stuck in the common bile duct, it might get stuck at the ampulla, and then you have pancreatitis, and then you're a lot sicker. So, yep. And then some other things, you'd also do NPO, IV fluids, antibiotics, GI consult for an ERCP, and then a lap cholecystectomy. Perfect. Okay, scenario 3. We have a 67-year-old obese and diabetic female with a past surgical history significant for a ventral hernia repair 10 years ago with mesh. They're not going to know if it's mesh, but this patient had mesh. Presented to the ED. They have a 3-day history of generalized abdominal pain, nausea, and vomiting. What are you guys thinking? Yeah. Adhesions, obstructions. What else?
Also just be infectious.
Yeah. What could it be? Don't pigeonhole yourselves.
Like gastroenteritis,
Yeah.
any kind of foodborne.
Mm-hmm. You'd said something earlier about people with diabetes.
Yeah, it could be DKA.
Could be
Even
DKA.
in an older patient,
100%.
she doesn't monitor
Mm-hmm.
her sugars.
Yep, 100% could be DKA.
It's kind of stuff, like a little bit at the end, the nausea, vomiting, and generalized.
Yeah, I gotta tell you, I added DKA to this differentialist today. Yeah, so my advice when you get a patient like this, y'all really clued into the ventral hernia with the mesh, but don't think about that like first. Think about first, you have a 67-year-old female with generalized abdominal pain, nausea, and vomiting. What could it be? And then like you got your differential, and then you're like, okay, so she's obese, she's diabetic. What then could it be, or what's more likely? And then also she's had a hernia. So what else could it be? Because you don't want to like get stuck on one thing and then miss everything else.
Could it possibly be like a UTI?
Could be, yeah.
The bowel obstruction, or like a perforated bowel,
Mhm.
something like that, because you said she had a hernia, and like.
So appendicitis, acute cholecystitis, pancreatitis, a UTI, diverticulitis, small bowel obstruction, hernia, gastritis, and DKA. I think we eventually hit most of those. But just don't pigeonhole yourself. It could be anything, for sure. But yes, the most obvious one would be what you guys said first. So gathering history, what would you ask her?
And it's like, did you eat anything funky?
Mm-hmm.
I don't think about any.
Bloody stools?
Bloody stools, yes, yes.
Have you noticed weight loss, like signs of cancer?
Signs of cancer.
Yeah.
She's a 67-year-old female. What else does she have had by now?
She had a colonoscopy.
Colonoscopy. And she had a colonoscopy.
Any fatigue or weakness?
Yeah. So like I said, like, right, so this could be cancer. This could be a colon cancer that has then caused an obstruction, but slowly, so now she's obstructed, she's having abdominal pain, nausea, and vomiting. Yeah. So the pain might be different, like you might not feel it. I can't tell you, I've had the diabetic old people, they don't feel the same as young people, and they can get a lot sicker. So, fever, chills, nausea, vomiting, diarrhea, constipation, changes in bowel pattern, and then the caliber is also important, because if they have a mass, then the change in caliber, right? DACA normally poop normally, now it's pencil thin, that kind of thing. And then blood and stool. Loss of appetite, is she hungry, not hungry? Has she had a colonoscopy? And then what type of diabetes?
Right.
Is it controlled?
Yeah.
And is she on insulin? I'll go backwards. This is our differential. So physical exam. What is peritonitis? Inflammation of the peritoneum. So peritonitis is inflammation of the serosal membrane that lines the abdominal cavity, otherwise known as the peritoneum. Your visceral organs themselves do not have pain receptors. So when your appendix is inflamed, my appendix doesn't hurt, my peritoneum hurts.
Right.
Do you guys know what kind of somatic receptors your visceral organs do have? They don't have pain. They have one. They do have one.
Pressure. It's
Hello? They can't tell if it's spicy. They can't tell if it's hot or cold. They can't tell if something's sharp. Stretch. So they do have stretch receptors. You can feel bloated. You can feel that, but you can't feel pain. And then what are the physical exam findings of peritonitis? I can't tell you. I asked my intern this other day. I'm going to give you a hint. The answer is not fever. Okay. Yeah. What are the 3 physical exam findings?
Tachycardia.
Guarding, rigidity, abdominal.
Those are 2, guarding and rigidity,
And rebound.
and rebound. Exactly. So those are like your 3 exam findings that you want to either include that your patient does not have or that they do have. And then, so guarding, rebound, rigidity. What is guarding?
Voluntary, which is the abdominal muscles. It could also be involuntary.
That is a distinguishing factor. If it's voluntary guarding, it's not generalized peritonitis. They can control it, right? They out there, they are doing it to protect themselves. Involuntary is that they can't control it. You go to palpate them and then they flex and they tense up to protect themselves. And no matter you tell them relax, 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 you put their knees up, whatever, they're not relaxing. Rebound. What's rebound tenderness?
Press down to release hands.
Yep. What about rigidity? You guys ever felt it?
Not soft. Palpation.
Yeah. So once you feel it, you will know what this feels like. Kind of similar to compartment syndrome in like the limbs. It feels like that. They are rigid. I remember the first patient I ever felt this on. And then when I'm talking to a patient, one of the things that I think maybe you guys were taught this in med school. I was taught this in med school. I was taught to ask them, hey, how was that car ride over here? Was it painful? Like every bump you hit? Like was that painful? Or sometimes when I'm talking to the patient, if I'm trying to figure out if maybe the patient is a little bit anxious and telling me their pain is 10 out of 10, but it doesn't really make sense with their labs or vitals, when I'm talking to them, I'll kind of like hit the bed gently and see if they notice it. Like, does that hurt? Or you just see. So those are your 3 exam findings of peritonitis.
I think we have someone who wants to ask something.
Yeah.
Go ahead, Mallory. Oh, she's typing now.
Nice. So,
Okay, she said that she's not gonna unmute herself. She'll stay in the chat.
okay. But I can't see the chat.
Yeah, no, I have it.
You tell me what it says later. Okay, so you have a peritonitic patient. What do you do? There's a lot of things you do, but the end game, OR.
Right.
Yeah. Then this is emergent. This is a sick patient. So if I'm calling my attending with this, that's something I'm going to lead off with. Hey, I got a urgent consult peritonitic patient. Right? I probably know a little bit more, like why are they peritonitic, but go to the OR. So bowel sounds. How many of us surgeons walk around with stethoscopes? None of us.
None of us.
So real life versus medical school. What are you guys taught to do?
Auscultate for bowel sounds.
Yeah. All 4 quadrants, and then you're told to document this like normal active bowel sounds times 4, right? Doesn't mean anything. So if you are listening to the right upper quadrant and there's no bowel sounds, but the right lower quadrant has bowel sounds, does that tell you anything? What?
Maybe they eat.
It doesn't tell you anything. Sure, for the most part, your ascending colon and descending colon are kind of stationary in the same part, but like your small intestines can be anywhere and they move and they're mobile. So just because you have something, no sounds here, doesn't mean anything. Also, you are taught to inspect the abdomen, listen to the abdomen, and then palpate the abdomen. And I looked into the history of this, and the reason why it's specifically this order is because they're worried that upon palpation, it might like make you have vowel sounds or like change your what you were beforehand. But like that's not real life. What about absent vowel sounds? How long do you have to listen?
5 minutes per quadrant.
2 minutes.
2 minutes per quadrant. Never have I done that.
Maybe it's like, if you listen to vowel sounds, you like it doesn't mean anything.
Yeah,
You didn't
yeah.
listen for 2 minutes.
It does not mean anything. Medicine may have different opinions, so I'm not trying to mess you up for your rotations and other special, but like for us, vowel sounds don't mean anything except there's one vowel sound that is specific for a pathology. However, we don't carry stethoscopes, so we don't hear it. Does anyone know? There's one very specific vowel sound for obstructions. Tinkling. Tinkling. I've never heard it. No carry stethoscope.
I'm so glad you mentioned that. I wrote it down.
Oh, really?
So
Okay.
like, it was a thing back in the day for us. We definitely had to carry around stethoscopes and listen, and high-pitched tinklings. Once you hear them, you will never forget them. And so even though like I don't routinely listen to them anymore, it is helpful. Like there are some exam findings for some people, vowel obstructions, hypoactive vowel sounds where you're listening, you really don't hear anything. You're not following the 2-minute rule, but if you're listening on a regular basis, you will notice a subtle difference. But the high-pitched tinkles, it's just, it's basically like imagine the contraction of gas and then like the fluid just slowly trickling through. And that's kind of what it sounds like. But yeah, it's not like you're going to action upon that.
No.
It's just in addition to everything else, and interesting to kind of hear it.
Yeah.
We have a comment in the chat. Mallory says that she never used her stethoscope once, even during her GI rotation.
Then they're the experts, so there you go. Okay. So our patient, her heart rate is 115. Her temperature is 101.2. Her blood pressure is 90/60. Moderate distress. Sinus tachycardic. There is nothing wrong with her respirations or her chest. Abdomen shows a non-rigid, obese abdomen. Tender to palpation in all 4 quadrants. She's distended with guarding and rebound tenderness. She has no palpable masses or fascial defects. However, fascial defects may be hard given her body habitus to appreciate. And then she has a previous midline abdominal scar that's well healed. Is she peritonitic?
Yes.
Is she sick?
Yes.
Yeah, she's pretty sick.
Yeah.
She's tachycardic. Her blood pressure is low. She's febrile, and she is in some distress. That also can tell you a lot. And then also just on old people, any altered mental status. You need to pay a lot of attention to that.
Right.
And then she's peritonitic. So what is the most common cause of small bowel obstruction in the United States? What's the next one? Tumor, hernias, all those. What's the most common in, I think, the world? In the world is hernia. In the United States is adhesions. So adhesions are 60%, cancers are 20, hernias 10, small bowel obstruction, inflammatory disease, Crohn's, right? 5% intussusception. What's intussusception? Exactly. Volvulus, what's that? Just twisting. And others. So different types of hernias. So you can classify hernias by location. So you have inguinal hernia, femoral hernia, ventral hernia. Ventral hernia also incorporates epigastric and umbilical hernia. It's like a square is a rectangle is not a square type of thing. Hiatal hernias or incisional hernias as well. Like an incisional hernia will also include like a port site hernia. So somebody said laparoscopic surgery, they used the big port, they didn't close it, or the stitch failed. Port site hernia. And then also got some fun ones. Anyone knows what these are?
pantaloon and Dr. McCoy?
Pantaloon is both a direct and indirect inguinal hernia.
Exactly. Looks like a pair of pants. What about a Richter? So a Richter hernia is where you have, it's not like the loop of bowel that goes through the wall. It's one of the bowel walls goes through the hernia. So that the loop doesn't go through, it's like one half. That kind of makes sense.
Like one of the layers go through?
Yeah, so like exactly what you show in your shirt, like your one layer goes through, not the whole loop, one layer. And then with that, you're gonna get a little worried about some ischemia to that area. Spigelian. So this is a type of hernia, Absite loves it.
Is
It's
this
a
the
non
one that's like in between like your rectus abdominis and your internal obliques, but you can't palpate it?
semilunar. Yeah, you can't palpate it, exactly. But they're gonna have tenderness there. And the amnions. Hernia that contains the appendix. Most of the time when we see these hernias, we end up taking the appendix out. And then you have,
hernia with the appendix in it.
yeah, you take it out or do you leave it?
No, it was normal.
Fair. Bioreducibility. Sometimes when you have a hernia that has the appendix in it, when you're trying to reduce it, you can make the appendix really mad. Or sometimes it's already mad, so we take it out sometimes. Bioreducibility. So you have a reducible hernia, an incarcerated hernia, and a strangulated hernia. What are the difference between these three types of hernias? Fair?
Strangulated is death of the bowel, but incarcerated just means that it cannot feed.
Yep. So a reducible hernia makes sense. You can push it back in. An incarcerated hernia, I remember it's incarcerated, so it's in jail. It's fine. It's alive. It's in jail. It can't escape. It can't get out. It's in jail. And then strangulated, I'm cutting off your blood flow. What timeline? Your test love these. When do you schedule a patient for a reducible hernia? Is this elective, urgent, or emergent? Elective.
Elective.
Yep. There's a couple like femoral hernias and operator hernias that are not. You're gonna fix those. But otherwise, especially if it's asymptomatic, elective, all that. Incarcerated. So urgent, emergent, or
It's emergent.
Because it could become strangulated.
it could become strangulated.
Depending on like how stable they are and their like vital signs, maybe.
Nothing's dead. Right, it's just in jail. So urgent. This is an urgent repair. You can't reduce it. You're worried that it could become strangulated. Exactly. It's not strangulated right now. And then so like urgent tomorrow, the next day. Also, if it's incarcerated and it's a loop, you could be worried about an obstruction. What's strangulated? Emergent.
Emergent.
You got a patient with a hernia. They got some redness on the skin over the hernia. Pretty tender. What are you worried about? Do you ever try to reduce a strangulated hernia?
No.
Why not? In the rupture, and then you can become peritonitic, and also then you can't find it. If it's strangulated, it's incarcerated, it's stuck up there, you can find it a lot easier. You know exactly where it is. But if you reduce it, you gotta go searching for it. And now, if it's perforated, you got poop all over your abdomen. I've seen one patient this happen to. You can become peritonitic. Another pearl on these is lactate isn't necessarily accurate because you can have dead bowel in a strangulated hernia and a normal lactate. You don't know why? Yeah. Exactly. There's no venous return, so you could have a normal lactate. So just because the lactate is normal doesn't mean not strangulated. A lot of times you still have a lactate, but Exactly. Good job.
And a lot of these, even the more common ones, you can't feel. Your body habitus is typical American. Just oftentimes you can't feel any of it. So you have to have a high level of suspicion and, err towards some imaging if necessary, especially if it's like a subacute or acute setting.
So back to our patient about this abdominal pain, 3 days, nausea, vomiting. We saw that she was tachycardic, she is febrile, she is paratitic, and she is in moderate distress. What would I order for labs? CMC.
CMP, lactate.
I don't think it's I would order a CMP in this patient. Yeah.
Just a lactate.
Lactate. Anyone else? I still did a UA. And then troponins, blood cultures. She's sick. She's septic. She meets sepsis criteria. Blood cultures. What do I do first? Blood cultures or antibiotics?
Blood cultures.
Okay. And why do I do blood cultures times 2?
Thank you, sis.
What if one of these blood cultures comes back positive for staph epi? Yeah, so skin flora typically want 2 out of 2 positive. Other little pearl, if they have a central line or a PIC line or a midline, you would want one of these samples drawn from that line and then the other one drawn peripherally. You would never want both the samples drawn from the same location, the same line. And then troponins as well. So, what's wrong? Lactate's high, 3.1. Ropes negative.
Mixed leukocytosis.
Yep, white count's 19.
Acute kidney injury.
Yep, and that creatinine is 1.9. Yep. So, what imaging would you order? Of? With? Perfect world. If she was
A
alert.
CT without contrast.
Because you're talking about that creatinine.
Yeah.
That's a really good point. Because my patient's so sick and I'm a surgeon, I would get it with probably contrast. Because I want to see her intestines.
And the creatinine clearance actually for IV is 35.
Yeah.
So
Okay.
her creatinine clearance probably is okay. But yeah, I would agree. Like the information benefits outweigh the risks at this point.
And then if she probably not for this patient, but because she's sick. But if you're a little bit less sick, I would also maybe want some PO contrast as well. All right, so some radiology practice. This is not our patient, but what do you guys see?
The hair, under the diaphragm.
Yep. So this is our X-ray. The easiest place to see free air on an upright abdominal X-ray is above the liver. So here is our diaphragm, and here is our liver, and then we got this air. Same thing on this. Which will be my favorite view. Got some air right here.
And something else that's good.
Well, that's fluid.
Yeah.
And remember with microperfs, you may not see any free air in a plain film.
True. And like sometimes you're just gonna get like a little blip like that.
Yeah.
Or like that. This also is some portal venous gas. What's this? Nope. That is a big rectum. Fair, but no, not what I'm looking at. This was funny to me because I showed my UIC med students too, and they didn't know this. But I feel like this is something that was hounded into me when I was in med school.
Oh, is that the apple core?
Contrast.
Yeah, so this is a fruit at the end of me eating this fruit. Apple core lesion. What is this? Cancer.
Carcinoma.
Yeah, apple core lesion right here and right here. Looks like an apple core. This is the tumor right here. And then this is all the little string of contrast that's getting through. Same thing right here. Just a little string of contrast getting through.
Not completely obstructed though.
Yep. So apple, apple core lesion, not obstructed. I'm worried about cancer. What's this? Helpful arrow signs.
Oh, is that,
This is technically a CT scan of diverticula. Difference is just diverticulitis is inflamed. I kind of would argue that this one looks a little bit hyperemic, but yeah, but there's no like terrible fat stranding. There's no fluid collections, but yeah, this is diverticula. Could be diverticulitis. It is air, but it's inside the colon.
Gotcha.
This. Which one's which?
Decal is on the left, sigmoid is on the right.
Exactly. So this is your cecovolvulus. This is your sigmoid volvulus. Exactly. So this is our patient's CT scan. Anyone see anything in this?
there's, isn't there like on the right side, or the left side of this image, isn't there like some adhesion like pulling the bowel up to like the abdominal wall?
No. That is air, but this air is inside of the colon. So here's my wall, and here's my wall, and then here is the air. Because my patient's laying down, right, and air rises to the surface. So here are some fluid-filled. These look normal to you guys? It's small bowel, kind of thick. It's also kind of. Does it look like it's the normal diameter?
No.
Extended. So right here is a transition point.
Oh.
So here's a bowel, and then it's a big change in caliber very quickly. So this is a obstruction, and here is my transition point right here. So CTs, small bowel obstructions, and transition points. So this is something called a whirl sign. A whirl sign is when you're twisting of the mesentery and twisting of the mesenteric vessels. So you can get the small bowel twisting on itself. I have seen this before. And this is also something that you can see in an internal hernia. So whirl sign on the left, right, anatomically the left side of the screen, normally the right side of the screen. This is air fluid levels. So you can see these air fluid levels in distended bowel, and then criteria. So the small bowel should be 2.5 centimeters, but bigger is obstructed. I've actually 2 centimeters, but bigger is dilated. And then as we
And
saw,
those little, the valvula canal ventes, can you show them on the plane? Yeah, the little plicae basically, and you can see them.
yep, right here.
That's how you know it's small bowel.
So I think they should be.
And then, okay, so
Oh, can you go back to that one?
Yeah.
Oh, it's not really, I thought it was good. So if you look in the right lower quadrant of the plain film, just imagine all that other gas is not there. Sometimes when you see what viscosity of gas, you'll see that all the time, like in your exams. Is another sign of obstruction. We just see no gas. It would all look kind of just like this whited out area on the right side there.
there's no gas distal to the obstruction. There's nothing in the rectum or the colon.
Or see, you're saying like on the left side of that image, there's like a bunch of like gas bubbles.
But not your typical amount. Like if you were to see a normal one, you'd see, yeah, gas everywhere.
I guess
Like a little more.
like right here, you got some. So our patient, exactly the same patient as I gave you guys earlier. So she's tachycardic, hypotensive, febrile, lactates elevated, CT scan shows a small bowel obstruction.
Open or not?
Either. Depends on the skill of the surgeon. But what else would I do for this patient? More like
Well, there's one
holistic.
other issue with the treatment, the surgical choice, and we look at, she has
Yeah.
a history of with, yeah, I mean, it's not a full contraindication, but I mean,
Yeah.
I don't know. I don't know if that's one, anybody would want to do that.
Treated too.
I'm sorry?
You have to like, think about like cancer treatment.
Well, she doesn't have cancer.
I was just-
We don't know that right now. That was like totally something that I wanted you to get to in the differential for sure, because you have an older patient
Gotcha.
with abdominal pain, nausea, vomiting. But we don't, now, she's had a prior surgery, so the most common, she's in the United States, so the most common reason that she would have this obstruction would be from an adhesion. But when I take out the bowel, I'm gonna send it to pathology, and pathology will then tell me.
And we don't see adhesions on any type of abdominal. Like, you just don't see them. I mean, you intraoperatively see them, but, you get the suggestion of something being like the itis of like an obstruction, but you're not gonna actually see the adhesive glands on
No.
the
So,
Thank you.
So what do I do for this patient? Yes, surgery is definitely in this patient's future. What else do I want to do for them? NPO, IV fluids,
antibiotic.
IV
NG
antibiotics.
tube.
NG tube, yes. I prepped this. Yeah, so NG tube, because she's nauseous and she's vomiting. So we have IV fluids, antibiotics, NPO, NG tube. One other thing that I would probably do. Her creatinine's pretty high, if not up there too, right? What else might I want to do? A sick patient. I want to know what her urine output is.
Oh, I thought you were.
Yeah, so I'm putting a
Foley.
Yeah, a Foley, exactly, a Foley catheter.
So what if the nurse says, hey, doc, I mean, she's not vomiting, she's not nauseous, she's feeling better. I don't think she really wants this NG tube. We don't have to put that in, make her hold off on it.
I'll do it. Do it anyway, right?
We don't think the person's trying to get out.
So,
Okay, all right. What if she's feeling a lot better?
You can clamp it and hold.
Well, I mean, in a subacute setting or acute setting,
a lot better and like his past.
hasn't vomited in the last couple
Past
hours.
gas or like have a vomit.
Still, yeah, same scenario.
Oh, no, there's no gas, no vomit, then I was stuck.
And then what about if she's refusing, just flat out refusing, absolutely no way are you with that? Well, not necessarily. I mean, the biggest thing I want you to do is document that she's refusing. Yep. What happens, actually, we had a case like this at my previous practice where somebody came in with a bowel obstruction and wasn't vomiting. Everyone's kind of trying to get away from NG tubes, and ER sent the patient to the floor without calling the surgeon. Surgeon didn't find out, going to the next day. And the patient was not vomiting, was okay, but had a bowel obstruction that was read out as a bowel obstruction.
Mhm.
And during the night, had nemesis, aspirated, and died. And of course, everyone ended up in court on it, but it was a shame. And so if somebody has bowel obstruction and you NG tube, if you're unable to put it in or they're refusing, it needs to be documented. And I would always document in your note the recommendation for NG tube, from my perspective, when it comes to obstructions, because bad things happen.
And I always tell the patient, hey, this is uncomfortable going in, doesn't cause pain, feels weird, uncomfortable, not fun, but most patients do feel better after it's put in because it decompresses them. So it helps with their pain, they're not nauseous after it's in most of the time. And I've never really had a patient immediately after I put it in. Most of the time they're like, oh my gosh, I feel better. Now, day 2, they might want it out because it's annoying them, annoying the back of their throat and their nose. But in the acute setting, I've actually found that it helps and it makes them feel better. So I tell them that, and also tell them the risk of if you throw up, maybe you're a little bit sleepy, like you had some pain meds, you're not really with it, there's a chance you could breathe this in and get really, really sick. So I just tell them all that too. Okay. Oh, so, nope, back one. 2 large bores IVs, fluid bolus. I would actually bolus her. She's an older lady, so I'd be cautious with the amount of fluid I'm bolusing her. I don't want to throw her into fluid overload, but I'd give her a little bit of a bolus. Blood cultures and then antibiotics and G-tube Foley, and we'd be going up to the OR. And how quick would we be going up to the operating room? In my peritonitic septic patient. Emergency. Yeah, we're going.
Emergent.
Yep. So now, same patient, however, labs are stable, vitals are stable, abdominal exam, she has some pain, but there's no signs of peritonitis, and the CT scan is concerning for partial obstruction, or maybe a developing obstruction. How could you treat this patient differently than our other patient?
You can bolus.
Yeah, fluid, sure, but I mean, in like the long run, our last patient was inevitably going to the operating room, 100%. As soon as we saw her, she's going to the operating room. What can we do with this patient, maybe, that we couldn't do with the last patient?
I think we're gonna just,
Somebody said the right, yeah, yes, monitor, but the other word is conservative management. And what would conservative management look like for this patient?
Same thing, minus the OR, I believe.
Yeah, same things. I would argue maybe not antibiotics in this patient, because labs are normal. She's not febrile. There's no signs of peritonitis, so you can have like non-infectious causes of small bowel obstructions. I do have some attendings that obstructed antibiotics right away. I might not in this patient, but conservative management. So NPO IV fluids, so them get pain medicine. The important thing is that you're going to check on this patient very routinely. You're going to do serial abdominal exams on this patient, and you're going to sign that out to whoever's on overnight. Every 2 hours, go feel the belly, because if it's changing, you can always then reassess, and you can then go to the operating room.
And it should be documented. And at the time you're doing that, you should also be checking their vitals again. Their urine output's very, very important.
Yep. And then antibiotics and G-tube Foley. Antibiotics is the question mark because I was talking about earlier. I probably wouldn't give this patient antibiotics. I do have attendings that would.
2 questions. One, for a diabetic person, would you ever consider antibiotics even if it's not your normal?
Why?
I mean, because they're more prone to infection.
They are more prone. If you're, let's say, type 2 diabetic, she's well controlled. Her A1C's 6. Not always.
And then 2, what kind of pain medication?
Good question.
She's NPO, right?
Yeah.
So we got two big options in the hospital. A lot of morphine. We're getting away from that.
No, I wasn't that. I actually still am of the mind that I don't really,
PO?
no pain medication.
Oh, no pain.
You don't want to mask an evolving picture. So I would say, I would probably err on the side of probably just call me if the patient's having pain, and not order like around the clock PRN medication.
Yeah.
That's really an important point. Now, sometimes you get a level of comfort, it's non-operative,
Yeah.
you know that it's pretty stable, they're stable, and you may have like that window, that few patients that you're okay ordering something. But I would say, especially in an internship and just in general, like, I wouldn't order like around the clock pain medication for like an abdominal pain patient that you're monitoring. That doesn't mean they can't get pain medication if they need it, but you want to know if they need it.
And then, obviously, if they're requiring more and more pain meds.
Yeah.
Sure. Yeah, and a Foley. Questions?
I have a couple comments before you do that. The character of the NG output is probably one of the more important things when you put the attention in. So if you put it in and it's just kind of a golden brownish yellow, what are your thoughts about that? Yeah, that might be kind of like a classic, you know, gastric lymph type of output. Obviously, if it's a liter of that, we know that probably they have some semblance of an obstruction. But if it's like thick, but more importantly, if it's got like a thick brownish
Green.
Yeah.
What?
And then also an odor.
Brilliant.
Bilious, yeah.
Mhm. And if you smell something that smells like stool, that's super concerning. That's called feculent.
Oh.
Oh, yeah. I'll show you some pictures.
Seen it.
Yeah.
Gross.
Yeah,
And
it's
they actually,
you'll never
before they
forget it.
put the NG in, or like throwing it up first, when they
Oh,
can.
Yep, I've had
Okay,
pictures.
so go through the.
Yep. So now we're gonna practice. We're not gonna do the Foley maybe, but we're gonna do the
Yeah,
NG2.
no bully today.
Do you like the setup? I actually switched the order of the scenarios so that we can do an
We
NG2.
appreciate it. Wait,
Um,
so where is the camera? Is that the camera?
That's a camera right there.
Oh, okay.
Just in the back of the.
Yeah, this is just really fast. I'll show you this. This is an X-ray. After you put an NG tube, you always have to get an X-ray
Mhm.
to make sure the NG tube's in the right spot. There is specific phrasing that you would use to tell somebody that this NG tube is in the correct spot, that you can confirm it's in the stomach. And the NG tube should pass midline below the diaphragm. And that's like how you can tell that it's in the stomach. This one is looped, obviously. Come back up, and then if it were like to come down and then go like that, it's not. It's where it's in the airway. And obviously, look at this before you feed anybody.
And we both have stories
We
where
both have stories.
it seems like it can't happen. But like when I was a resident, somebody got job offies in their lung for a few days. It was really bad. And then
Yeah, I had one with SICU when I was a trauma senior. Somebody started these in the lung. And then my intern year. This is a Dobhoff tube. Does anyone know the difference between a Dobhoff tube and an NG tube? And what can an NG tube do that a Dobhoff can't do? Suction. Yeah. So this one's smaller. I had my first M&M ever as an intern was on a Dobhoff tube on somebody who couldn't get the Dobhoff tube in. So I came to help. And the patient got a tension pneumothorax from this. So the Dobhoff tubes are actually more dangerous than NG tubes because they're smaller and they have this metal tip, so I can push it through things a little bit easier. 3,000 to 4,000 people a year die from NG tubes and Dobhoffs.
how many did you say?
3,000 to 4,000.
1,000?
Because if you think about it, so many people have them, and so the people pull them out and they get reinserted. They pull them out, get reinserted. So, yeah, 3,000 to 4,000. I know that from my lovely M&M. Yeah, so Dobhoffs are a little more dangerous because they can get into small airways. But obviously, make sure you're not feeding a lung. Make sure it's correctly positioned. I've also heard horror stories of you would never put one of these in somebody with a basilar skull fracture because it can go up into the brain.
Yeah.
So any type of like nose basal face fractures, like abundance of caution before putting one of these in. Cool.
I have a question. If you got into the lungs, wouldn't like the sign be like if they like started coughing or something like that? Like, yeah.
However, I think
Maybe
if I were to put a tube down your nose and mouth with lube, you're like, you're gonna cough.
Yeah.
Or is that persistent cough?
Sometimes you can actually hear it. It's more of like a tracheal stridor-y thing, and you know you're kind of in the wrong place. But yeah, they're gonna have cough regardless.
Yeah, but and then if a persistent cough, I would have hopefully had an X-ray by then anyways.
Always do an X-ray after you put them in.
Yeah. Okay, so I don't know how to show everybody at once, but
Go to the other screen.
Oh, sure, yeah.
Just ask the main after. We've got about 10 minutes, so we can, so people don't log off.
okay, so human,
Oh, okay.
yes. I was like,
That's okay.
Okay,
I
human.
can do it again.
Human. So assuming my patient is alert and oriented and can participate in my exam, they're not a trauma patient, they're not in a C collar, I would have my patient be sitting up in the bed, like actually move the head of the bed up. And then how you position them is you have them tuck their chin to their chest, like this, because that will help you with the angle of the NG tube. And then if the patient is able to, you would have them take a sip of water, because that can also help you get the NG tube back. So you have them, get them in the right position, give them a little cup with a little straw on it, and then you grab your NG tube. You always want to lube it up first, the chin to chest, and we know what the position is.
It's, like the left.
It's called sniffing.
Oh.
Sniffing position. And then you can kind of measure how long you would need this to be by planning it. And it's like tragus to people teach you here. However, standing, you can always pull it back. So you push it in. I get it to about 65 for most patients. Then you have them in the position, their head's tilted, this is lube, they have water. You put it in the nose. That's the mouth. I'm upside down, okay? So in the nose. And I kind of put it there and I let them kind of sit for a minute, get used to it. By a minute, I mean a couple seconds. And there's two places you're going to feel resistance when you're putting it in. One is right at the back of the pharynx, right here. You're going to feel some kind of resistance. So I kind of stop for a minute there. Also, by a minute, I mean a couple seconds. And then you advance it. And then the next place you're going to get some resistance is like at the epiglottis. So that's where I have them sip some water, because that will open and that will facilitate this going down. And then once you're past that point, you can just feel it. And it's like, okay, now we're in, and now we can go down.
Sipping water, I usually use a straw.
Mhm.
It really helps. Because they get kind of concentrated on the water and drinking, and then the normal physiology happens, and it just.
Shove it.
The other thing that can happen is the turbinate's there. That's why sometimes you pull this out, get all this bleeding that's scary.
Mm-hmm.
It's just from an abrasion. I think the other thing is some people who have the turbinates or I don't know,
Allergies or
something weird that it can get hung up in that area.
Mm-hmm.
So,
And then sometimes you can have a hard time with one side, but then the other
Yeah.
side.
for sure.
Super
Always
easy,
try
so
both
try
sides.
both sides.
And then I don't think I have a real tumi, but what's important, the first level of checking your NG tube is
You gotta listen to the stomach, right?
Yeah.
You insert air, and then you'll hear it.
and you'll hear it. It's really very easy to hear,
Mhm.
but it can really be throw you off too. I mean, it's definitely in the stomach, and then the imaging comes back and it's not. So it's just not enough.
Yep.
And can you explain the slump, just what
Yeah.
what to put them on?
So the suction goes to, so there's a blue port with a little thing on the tip of it. And then there is the actual NG tube itself. The actual NG tube itself, this is a connector, and then this goes to wall suction. And then do you guys know what kind of suction I hook this up to? So NG tubes go to low intermittent suction. Chest tubes, continuous, exactly. Dr. Chaudhry right now is on a kick of putting all NG tubes to continuous suction. So just caveat if not trauma. But standard teaching, NG tubes go to low intermittent suction. Chest tubes are continuous suction.
Because they can affix to the wall of the stomach and sometimes cause little ulcerations or bleeding. But I think either way is fine. And one other thing you can see there, just from anatomically speaking, how easy, unfortunately, it is to get that in the trachea. It just happens to go down the wrong height.
Yeah. Sometimes it's luck of the draw. And then, so then in the morning, what you see us do is we hate these on our tubes. So we all pull them off. Sometimes we even cut this so that they can't put one on. My absolute favorite is when this is tied in a knot. So what this does is this lets air in. So when it's sucking, if it does get stuck up against the wall, this will let the air and it stops the vacuum. So it can get unstuck. And so we flush these. We flush both of them. They both can get clogged. Any questions?
Two quick things. Okay, so how would you sign out those two cases, or like call your attending? You're calling me about those two last cases.
Anyone want to do it? Anyone
Yeah,
try?
someone wants to try it. Anybody remember that? And you can make up little details that if you don't remember everything.
So you got a 41-year-old guy who's relatively healthy, who has cholidoko, and then you have a 60-something-year-old lady who's really sick with obstruction and peritonitis.
Anybody want to try? You can make up little details if you don't remember it.
I'll
So.
try the 67 guy.
Okay, good.
Are you still recording? Or is this the camera?
So I guess if you're calling me attending, you guys were talking about how you say like more for surgery, like we have like suspected, or do you say confirmed like peritonitis and small bowel obstruction when you see the CT results? Do you say confirmed or like suspected? Like I don't.
I would say, hey, Dr.
Yeah.
Herron, I have an emergent consult,
Yeah.
peritonitic. I mean,
Yeah,
like
peritonitis,
yeah.
showing signs of peritonitis. She's a 67-year-old female. She has fever. She's been vomiting. She is looking pretty sick overall. She also has a history of diabetes, and I think that she needs to be taken to the OR right away. Yeah, and I've done all the steps, NPO, given large fluid bolus, but I think we need to come see the patient right now.
Okay, that's a good one. How would you do it?
Kind of similar. I think it's a hey, Dr. Herron, emergent consults, peritonitic, 67-year-old lady, diabetes, obese, coming with abdominal pain. She's peritonitic on exam, and septic. She's febrile, tachycardic, lactates 3.5. I'm worried that she has this obstruction. CT scan agrees. This is what I've done. This is what I got for you.
We still want to hear all the details. So you still, just like when you're in clinic and you're giving a whole like HPI, abbreviated of course, vital, like history, their past medical surgical history, the vitals, their exam findings that are most pertinent, the labs, the imaging, and what you think. So I would still, you kind of feel like, oh, I just gotta tell them, we gotta know our, this is of course the most important part, but I would still like put all the details in, because sometimes there's little nuances or something else we want done, or also help us determine the kind of timing of what we think needs to be done and that kind of thing. So that's important. Anybody online want to try the gallbladder to present that one? Rachel. Oh, you can make up details. You don't have, it doesn't have to be exactly the same case. Oh, I think she won. All right. Anybody else want to try?
Okay, I can go ahead. So, which one? The cholidoko?
Yeah, fully open.
Okay, so 41-year-old male with past history of diabetes and obesity, presents with right upper quadrant pain. Did we get ultrasound for him?
Yeah.
The ultrasound showed an edematous appendix, or no, sorry, gallbladder.
Oh, no, wait.
Edematous gallbladder, some pericholecystic fluid, and adjacent fat stranding, and dilated common bile ducts. And did patient already get ERCP, or I think patient should go for, and I would say I think the patient should go for it.
Okay, good. Don't forget vitals.
Vitals and the Billy.
No previous medical surgical history. Just want it like concisely. We'll keep practicing. That was good. Only other thing with that patient that I would have added for the past medical history is no one said aspirin, NSAID use. That would have been a really big important thing for like peptic ulcer disease. But it didn't end up being that.
I was going to put a slide up for peptic ulcer disease. I'm like, this is getting too long.
Okay, 5 minutes. We are going here. You go and pick a person. Okay, 5 minutes we need, guys. They're gonna pick. We got some questions for you.
Or something. I don't know. Can you help?
No, you don't have to stop it. I just don't want them to go away. Yeah, Mo, go over to that guy. Pick one.
Oh, we have helpers.
Yeah, read it.
You are following a patient being managed conservatively for perforated diverticulitis. BP remains 80/60 despite 2 boluses. What's next? He is, yeah, for diverticulitis. Definitely hypotensive. He's after boluses. I think we should go. Let's go on.
Okay, but in the meantime, just go to the OR. It's gonna take some time to.
Yeah, probably.
Anybody want to help? Anything else?
Like NPO, antibiotics, keep the fluids going.
Good. Yeah, you want to keep the fluids going, but re-examine them and make a plan for somebody who's not responding to conservative management, right? Okay, good. All right, let's see. Camille, we're picking one for you. Are you available? Not those folks are.
Yeah, she's unmuted herself.
Can you pick one for her? Can you talk now?
I'll try, yes.
Okay. Okay, you've got a nurse call, and the patient admitted for observation with a recently reduced right inguinal hernia is now complaining of abdominal pain. What else do you want to know when the nurse calls you?
Do you mind just repeating that one more time, Dr. Herron?
You have a patient who was recently admitted for observation with a recently reduced inguinal hernia. So it's reduced, it's not incarcerated. It was reduced in the ER, although they thought it was initially incarcerated. And now the patient's here for observation and complaining of abdominal pain. Is there anything else you want to know from the nurse?
I probably want to know what her vitals are.
Okay, good.
Febrile, not febrile. If she's hypotensive.
Good. Heart rate's 120 and no urine output since they've been on the floor. Just what would you think about doing next?
What does the stomach feel like?
Yeah, so exam, you can, if you're not able to go immediately, you'll send someone else, but you can ask the nurse, like, what is the exam like? And she may tell you she's distended, tender, but complaining a lot of things. You know, they don't necessarily examine the patient, right? So, anybody else want to help with this or any thoughts?
We would be concerned about
Okay. She had a strain, she had a reduced hernia. We talked about that a little bit, right? So it was incarcerated initially, somebody reduced it, and now she's having escalating symptoms.
Right.
So what do you think might have happened?
So it was irritated and they reduced it.
Possibly. So it might have been
Does she have any
strangulated.
nausea or vomiting?
Yeah, good question. And then, so yes, started to vomit as well. What do you want to do? Anybody?
Probably some imaging.
Well, we already talked about kind of the first step, like you're the intern, right? Got to go see the patient, right? You're going to see the patient. In the meantime, you're going to order some, what?
If
Labs.
she's vomiting, then we'd want to get some fluids and labs.
And make sure there's fluids running. Anything else?
We just X-ray and see if there's any free air.
Well, what would you do, Karen?
Okay, so I'll go see my patient first, foremost. I'd see what their exam is, peritonitis, when their last labs were. I would potentially order new labs. I would also be texting my attending, telling them like, hey, now I think this patient's peritonitic. Because it's really stable. He also hasn't made any urine. You mentioned that. So I don't know if there's a Foley, flush the Foley if they have it, or put in a Foley and then fluid.
What do you think about imaging?
Depends on the exam. But she's peritonitic, I don't need imaging.
Yeah. So definitely when everything's riding on your exam and kind of the vitals and the whole clinical picture, you may not even be waiting for labs. It's not the wrong thing to do some imaging or labs if you go and examine them and they're kind of status quo. You might be a little discomfort, but see a little tachycardia, you flush the Foley and there's still no urine output, then you probably want to escalate it regardless. So you're senior or you're attending. But then in terms of like, do we definitively want to do any imaging? Probably not if someone's like carotonic, especially.
I mean, in real life, all these things happen at once too. So like, you're getting them ready for the OR while you're ordering things, while you're calling people. So it's like,
yeah,
not like
everything's kind of
this,
happening
waiting.
simultaneously.
Okay, what labs are important to order in a patient with intestinal obstruction? What abnormalities would you expect? So you would order, CBC, CMP, urine analysis. You would order maybe liver enzymes, perhaps. Yeah.
And bowel obstruction, right?
Yeah, intestinal obstruction, bowel obstruction. Yeah, so maybe not liver enzymes for that.
So you know what it is.
Yeah.
You know it's an.
It's an intestinal obstruction. Yeah. So CBC, CMP, lactate as well. Yes.
What is pathognomic for like a bowel obstruction, or at least a complete bowel obstruction in terms of those labs? I always ask for this on your shelf exams.
What was the question?
Electrolyte abnormalities.
Bowels are they falling? Yeah, so hypokalemia, what is it? Hypo.
Okay. Anybody else? Magnesium is usually low. K is low. What was that?
Watch out for repeats. They haven't been, but
Yeah. Okay, let's see. Who else do we need? Did you get one? Oh, go ahead. We're over time, so we have to kind of rush a little bit. Let's get someone online. Felita, are you available?
Yes.
We got a question for you.
Okay.
Here, do that for
You are called for a 25-year-old female with severe lower abdominal pain. Her CT scan shows significant amounts of what appears to be free fluid in her abdomen. What is the differential?
Oh, man, that's
How old is she now?
25.
Easy.
Just
We went over this.
That we did.
Let's see if she's listening. Go ahead.
Yes, that was the case that we did, right? Essentially. So it's the free fluid, little bit of free air. What was it on the imaging?
Free fluid in her abdomen.
But significant.
Oh, it's significant.
Yeah.
Okay, differentials, lower abdomen, maybe like ectopic pregnancy.
What
Variant.
about an ectopic pregnancy though?
What was the question? Sorry.
Would it is the ectopic pregnancy, is it like this little fetus in a fallopian tube, or did something else happen?
Oh, Rutherford.
Ruptured. Yeah.
One thing that we actually did not address is like any female, no matter what the age, with abdominal pain, especially pelvic pain, they really should get a pelvic exam. I can't remember the last time I do that outside of in the OR, but usually the ER doc will have done it. It should have been done and documented in some way. It's super important, and especially in like childbearing age folks. Okay.
The nurse calls to inform you that the character of the EG output of reported partial small bowel obstruction recently admitted has changed. What's next? So I would like to know what the character is.
Yeah, it's really brown now, and it's kind of sticky.
So that is is that something?
Yeah, so it sounds like it might be feculent, which means that things are really not blocked, right? So what kind of questions would you ask the nurse?
How long ago has this, recently, I guess, what is the patient like? How is the acne? Vital signs, has the patient acne?
So heart rate's like 110, really seems comfortable, but it's just a lot coming out and it's really small. So you want to know the volume, but you don't want to be asking all these questions with the nurse. You want to go see the patient, right?
Go see the patient.
Period. That's it. Because then you go in there and they've told you that the abdomen is soft, you're not complaining. You go in there, distended, tympanitic, really uncomfortable. You know, you look at the NG, it's not only just speculum, but it's 2 liters in there, and you were just there 2 hours ago and there's nothing in there. So what thoughts do you guys have on the next thing to do in that situation? So I just described what the exam you found. Anybody? Well, I mean, that's kind of, yeah. So, I mean, we want to start with just like the immediate clinical things, right? So there's a lot of NG output. You might want to recheck labs. You want to make sure your urine output's okay, make sure it's properly resuscitated. If they don't have peritonitis, yeah, you might do some imaging. You want to let your team know that things are changing. Or even just observe and come back a couple hours later to see which way things are going. So, okay, let's do 2 more.
You've just completed placing an NG in a partial small bowel obstruction patient in the ER. She's waiting for admission to the floor. You're at the end of your shift. It's time to sign out to the intern night float. What's next? I let them know that an NG tube is placed for a patient with a small, partial small bowel obstruction. Make them NPO. Let them know what time it was placed. They need to order a chest X-ray for the NG tube.
You ordered the chest X-ray.
Follow up on the chest X-ray.
Okay, that's very start fluid. Okay, we just want to make sure you checked your own tube. Okay, that happens at the end of your shift.
Yep.
And it's going to take 2 hours to make imaging. Okay, let's see. Rachel, you're getting one. You weren't there. Let's see. Oh, you got a nurse call. The patient that was admitted for acute appendicitis was and planned to go to the OR in the morning for an appendectomy has a temperature of 38.9. The nurse is calling you about that.
Okay, so I'm sorry, you were breaking up. So the nurse called for a patient that has acute appendicitis and was supposed to go to the OR in the morning, but they now have a fever. Is that correct?
Okay. 38.9 fever at that.
Okay. So I would first ask if they received any form of pain medication like Tylenol. But I would also go assess the patient to see if anything has changed. So if the clinical picture has changed, especially like an abdominal exam.
Yeah, so they're still really tender in the right lower quadrant. You notice that the heart rate's like around 115. And that's the second above 38.5 temperature since they've been here. And it's 8 p.m.
Okay. So they're now tachycardic and it's the second recorded temperature. Is that correct?
Yeah.
Okay. So I think at this point in time, I would just do a quick revisit of the labs and then I would call the attending because they definitely meet serious criteria now, and I would think about potentially taking them to the OR now.
Great. So I'm your attending. Tell me, give me a call and tell me what you're going to say.
Okay. So I'll just say she's like a 38-year-old female that presented earlier in the day with acute appendicitis. We have an acute change. She is now have a fever ×2 is 38.9. She's tachycardic at 115. Clinical abdominal exam is still the same. She's still tender in the right lower quadrant. And I think she needs to go to the OR now.
Okay, great. Very good. What do you think?
That's good.
Yeah. Let's see. Did everybody get one in here? No. She's got that look. She looked away from
I
me.
know, no one knows.
Okay, okay.
This is like the least stressful situation too.
No,
I'm not here.
That was
Just like
fun.
shrinking in the air.
Very cute.
It's like my dog when she's in trouble. It's
I know, I'm not saying. You notice that the partial small bowel obstruction patient you were following on your services having increasing abdominal distension, nausea and vomiting. What next? Okay, this sounds like their partial small bowel turned into the small bowel obstruction. Next, you do reassess the patient, do an abdominal exam on them. And wait, do they have anything like an ND2 place or whatever? Just
Yeah, so well, you can assess those things.
yeah. So just further assessment, another abdominal exam. Do check vitals and repeat any labs, given the nausea, vomiting, fluids. You're an output.
Yeah.
I love your output.
Oh, yeah, that was good. Like, you know, so reassessing,
Yeah.
kind of starting from scratch and, you know, escalating it if you think it needs to be done. And if they're super sick, you might have to intervene. If not, you might just do some imaging or continue to observe, but circle back and see them again. One more. Hurry up, because we're
Well, you're
like
being
faster.
On my interviews for surgery residency, I got a few like scenarios, like pimp scenarios. Like don't be stressed out. There are a couple, but the right answer, like the first thing you do is always go see the patient. And you like, first, then I would go see the patient, and then like, okay, now you have the patient. Now what do you do? But go see the patient. That's your first step.
Okay, so I have a nurse call and the patient admitted for observation for abdominal pain has a heart rate of 130. What else do you want to know? What's next? So their heart rate is 130. What's their BP? Is that, you know, compensating for some significant hypotension? And have they gotten fluids? Have they been bolused? Are they still tachycardic despite that? Are they febrile, given that tachycardia? And based on the vitals and where this abdominal pain is, it doesn't say where it is, would depend on imaging.
Yeah, good. I forgot urine output, but you got everything else. But I mean, urine output sometimes is the very first thing to let you know something bad's happening. And the problem is a lot of times they don't monitor it very well or record it. So it's just, you know, another thing to kind of keep in mind when trying to reassess people. But yeah, it's just really about reassessing. And I really love the fact that you bolus them because sometimes you go see the patient and they don't even have no fluids. Yeah. And it could be as simple as that. Like if you examine them, the exam is pretty benign, but you know, their tachy, you're concerned, but they may just be getting further behind. Did you go over? Yeah. Okay. Is there another one?
Okay, yeah, I got a nurse call, urine output for your patient with a partial small bowel obstruction that is being managed conservatively is 3 milliliters over the past 6 hours. What do you do now, or what do you want to know? What next? Like, based on that. So I'm assuming like, obviously like urinary output is low, decreased.
3 milliliters?
Yeah, 3 milliliters. I don't know, like cross. Yeah, so it's decreased, and that could be like obviously like really horrible sign. So I would want to go examine the patient first. I check the patient. What are the vitals looking like? What's everything else looking like? The entire picture, like have they been bolused, etc. All the stuff we said. But then you might want to order repeat labs for CBC to check their creatinine and the BON, and even just check, maybe it would even check liver enzymes too. I don't know.
In our surgical patients, usually
I don't know.
worsening, we're not really worried about an acute kidney problem.
Yeah.
It's usually the result of under resuscitation or like worsening sepsis, SIRS, whatever else, you know. So I mean, that's good to look at all those things for your complete picture, but yeah.
The vitals are the most important. If their BP is like probably like really low now, or
yeah, it gives you a complete picture because the low urine output might just be like a problem with the Foley, but if it's with tachycardia and or hypertension or you didn't respond to a previous bolus, yeah. Wait, I think we have Alana, is that her name? Let her get one, because I think she's the only person that didn't get one.
Because what is shock?
It's hypertension refractory to the.
But like, what is it?
So it's
Not septic shock. What is shock?
hypotension, systolic.
And organ failure due to lack of perfusion. So if your patient is very sick, low urine output.
And what is low urine output? What is an acceptable amount of urine output?
It's very unhealthy.
Yeah.
How about a weight-based one?
One.
10 mil per.
0.5 greater than 0.5 cc's per kilogram.
So that's only five.
One is also correct. So it's greater than
And then how
0.5.
much do you bolus? How do you bolus?
30 mils per kg. It's based on weight.
So wait, yeah.
20 cc's.
Yeah, it's 20.
Yeah.
I mean, I
Yeah.
think, I don't know, it's a little different.
Everyone's different, or like if they have heart failure, it's different.
Yeah.
If they have kidney failure, it's
If
different.
this patient is like not getting bolus, then it could be causing like slow urine.
Okay, this is for Alana. We're almost done, guys, because we're over, sorry.
What type of IV fluid is used for boluses?
In surgical patients.
In surgical, yes.
Oh, yeah, absolutely. I read too.
No, did you get?
No.
See? Alana, are you on?
Yeah, sorry. What type of? All I heard was what type of IV fluid.
For boluses?
Is used for boluses for like our surgical patients.
Like normal saline. Jeez.
Okay. Is there any reason to choose one or the other? Anybody have any comments on LR versus 0.9?
I want to say someone stressed the importance of potassium.
What are your thoughts?
Potassium is one of them, but also repeated boluses with normal saline cause metabolic acid.
Bolus with LR. What about maintenance fluids? What do we like for maintenance fluids in our surgical world?
Is it mixed crystalloid?
Huh?
Mixed crystalloid fluids.
Yeah, so D545, normal saline with, is that enough? Yeah. With like 20 ppm. Yeah. And how do you calculate, well, we already talked about, no, we didn't talk about how you can calculate how much the appropriate fluid is for your patient, like a 70 kilo patient.
There's a calculator on MedCal. Okay, there's also a formula. There's also a formula.
I mean, you know, maybe, do you remember like how to do that?
Like total body weight.
It's like a formula. It's
Times
4
0.8 times 4 divided by
4-2-1 rule. Like you give what 4
yeah.
cc's for the first 20,
Oh,
and then 2 for the next 20, and then 1 after that.
I think just like, and at 30 mils per kg for the first 3 hours of the substitution. But yeah, I
Maintenance fluid.
Okay, and then I've heard of the 4 and
4-2-1.
yeah.
So if you're really in a bind, like D5W is fine, right? For bolus?
No.
What about for maintenance fluid?
And
why
this
not?
would be okay, because it's just like a trickle of sugar. So you don't want to just bolus them.
So yeah, we don't want to ever give D5W for boluses or even like, we use that for like free water replacement when someone's hypernatremic, but it's definitely not the choice on an exam or in person, because you could really hurt somebody.
Even if they're hypoglycemic.
Yeah.
Comes cell lysis.
The only time I ever use that is for appropriate replacement for hypernatremia, and you have to do it over an extended amount of time. It's like half the first 24 hours, I
Yeah.
believe.
And you can't lower it, yeah.
Okay, last one. Because you
Yeah.
didn't get one. Oh yeah, there's the last one today. Just enough. Yay.
Nurse call to ask you if she can bolus your recently admitted abdominal pain patient. What next? Well, first to course, make sure they haven't already been bolus, but, I mean, cool though.
Are you like, wow, thanks for calling, sure.
Well, I have to go down and see the patient.
Okay, good.
See what's going on, and if they've already had IV fluids, probably, do you continue to bolus after the first bolus, or is there a specific amount?
Well, you want to know why anybody would need another bolus.
Why does she want to bolus the patient?
Right.
Okay, why does she want to?
You got, that's the first thing you got to ask, I mean, before you even see them, because you're on the phone with them, right? Why do you want to bolus them? I mean, some people are like kind of rogues out there. They're really good at resuscitating and doing stuff, and like a patient's decompensating and they're handling it, but you have no idea why or what's going on.
Yes.
So you appreciate the call, but why? And then you ask the rest of the vitals, urine output, you go see the patient.
Yes.
So last question for Taryn. So you called your attending, it wasn't me,
Okay.
about that last patient, the
The,
peritonitic
yeah.
patient. And they said, not me, I didn't say it. Okay, well, add them on for tomorrow. Okay, it's like 7 o'clock in the evening.
I would say, kindly disagree. I think they need to go sooner.
Okay. And what's, oh, just, I think they're all right. Just give me a call later if anything changes.
I would continue to push. Go to the OR now.
Okay, yeah.
And then, yeah.
So, I mean, you know, I always try to have a real, like, it's important to respect the people that are there at the bedside taking care of patients. I might be home or commuting around or whatever else. And, you know, I don't have the benefit of like laying my hands on folks or seeing like things real time. And sometimes things get missed in translation and, you know, we don't hear the full story or we're preoccupied, you know, and that goes for your upper levels too. So if you're concerned about a patient or you see a change in their status or exam and we are not hearing you, it's important and a part of your responsibility to circle back and talk to us again or find other avenues if you need to. Okay? Because that's not okay to wait 12 hours for somebody who's paralyzed. They're not going to survive. Okay? And like anytime something like that's happened, I'm thanking you for, oh my gosh, thank you. I didn't realize or I didn't hear it or, you
It's
know.
also better to be safe than not. And then if like the attending were to be, I think we should just watch, like just continue to monitor them. And they continue to push, I'd be like, okay, and then I'd promptly call them back probably 10 minutes later and tell them that they're getting worse. And I still think they need to go. Yeah.
Any questions? Any questions online there? Thank you so much, Taryn. She had like a really rough rotation and she put this beautiful presentation together and gave us her time. And it was awesome. We appreciate it so much. She got amazing work. You're the reason I wanted to, I think you're a phenomenal resident. You're going to be our first one.
Oh, thank you very much.
Example.
I will help out whenever you guys want.
This is amazing. Thank you so much.
Hope you guys learned something.
Learned a lot.
You explained things really well. Like very like, it made